Welcome back. We're at Module 5.1, Midlife and Menopause Hormone Therapy. This is a midlife and menopause series. We're going to discuss the terminology. We're going to talk about hormone replacement therapy as well as menopause hormone therapy. Historically, we used the term hormone replacement therapy, and it was used broadly to describe giving hormones to replace the body of what it's no longer producing. However, the word replacement implies restoring hormones to the premenopausal level, which isn't actually the goal in menopause care. In modern practice, the preferred term now is menopause hormone therapy, and MHT, as we call it, specifically refers to the use of estrogen with or without a progestin or a progestogen, and depending on whether a woman has a uterus. And it's used to treat symptoms of menopause, prevent long-term health risks like bone loss and other things that we've talked about through this series. It actually reflects a much more accurate and individualized approach, and adjusting hormones to the lowest effective dose for management is not necessarily used anymore. We're not replacing things entirely. Professional societies such as the Menopause Society, the International Menopause Society, now encourage using that term MHT instead of HRT. And though both terms may still be in the literature, MHT is actually more precise, more patient-centered, and avoids this misleading idea of full hormone replacement therapy. So let's talk about the different types of hormone therapy. There's estrogen therapy, or ET, and it refers to hormone therapy containing only estrogen medication. Estrogen can be used as conjugated equine estrogen, often known as Premarin. It's a synthetic formulation. Estradiol, which is 17-beta estradiol, like what we produce in our ovaries, and that is bioidentical. Estraterol, and estradiol valerate. So lots of different options that are there. There's also estrogen and progestogen therapy, and that refers to estrogen with a component of an addition of a progestogen for uterine protection. We have to use progesterone when you still have a uterus, because if you give estrogen unopposed, it thickens that lining of the uterus, making you at risk for endometrial hyperplasia and endometrial cancers. Progesterone options include synthetic formulations like medroxyprogesterone acetate, or known as Provera, norethindrone, micronized progesterone, which is going to be what is bioidentical to what you produce in your own body. And then there's levonorgestrel. That may exist in a form, for example, like an IUD has levonorgestrel. Bioidentical hormone therapy, or BHRT, refers to hormone formulations that are identical or similar that are used in your body. We actually make FDA approved and non-FDA approved options, commercial, compounded, and we're going to talk about that a little bit more on the slide. So just because something says it's bioidentical doesn't necessarily mean that it needs to be compounded. Okay, so we have different hormone terms. There's commercially available FDA approved options, and those can be bioidentical as well as synthetic. So we do have bioidentical available options that are FDA approved. That's going to be something like micronized progesterone, like what you produce in your own body. And we also have estradiol, which is commercially available, FDA approved patches, rings, and gels that are also bioidentical to what you produce in your own body, and they are FDA approved. There's also FDA-approved synthetic options. A lot of people have fear around synthetic options, but there are some patients that may need a synthetic option, and I think it comes down again to that nuanced care and shared decision-making. Not everyone is going to do great on every single hormone regimen, and some people don't do as well on some of the bioidenticals. For example, micronized progesterone is great for sleep benefits, and it has a horrible bleeding profile, so patients can tend to have more bleeding when they use that option with synthetic, with micronized progesterone. So synthetic may be an option for them. Compounded medications as well exist out there, and as much as I don't use those a lot in practice, there are places where compounds make sense. Compounded medication is kind of a made-to-order medication. You may have patients that need to use bioidentical hormone therapy in different formulations, and this is where compounded medication works really, really well for them, because they may have an allergy or an intolerance. Also, testosterone is not commercially available, so that's again where compounded options may make sense. Okay, so if you're in the throes of perimenopause, treatment options may look a little bit different. So, some things that are really important to consider if you're in this perimenopause transition is that you actually may still need contraception. And if that's the case, you can look at birth control pills, birth control rings. IUD is a beautiful option, it works really well. A lot of times you may need some bleeding control. If you're having symptoms, sleep, mood, weight gain, fatigue, libido, pain with intercourse, those are all things to be thinking about. But I also think it's really important for you to remember that even though you may be in perimenopause, menopause hormone therapy or MHT is not a no. You don't have to stop bleeding or be in menopause to use menopause hormone therapy. So you're not bound to having to use birth control as your option in perimenopause. So that's one of the things that you should be talking to your provider about is what are your options, because you absolutely have them. So here again are some of the myths that birth control is your only option. That is not the case. Absolutely, you can use menopause hormone therapy, you can use an IUD and mix it with a combination of menopause hormone therapy. So again, nuanced care and shared decision making. I can't take hormone therapy if I still have my periods or if I've gone through one or haven't gone one full year without your period. Again, a total myth. You absolutely can take menopause hormone therapy. A lot of times we start with some progesterone. We'll talk about that further on in the slides. But yes, you can take it even if you haven't stopped having your period. And vaginal estrogen is only for old lady vaginas. Nope. A hard no. A lot of times as we start to go through this transition, our estrogen does start to plummet too, and you absolutely can and should be offered vaginal estrogen if you're having dryness, irritation, pain with sex, things of that nature. Your provider should be talking to you about what sex looks like for you. Are you having orgasms? All the things. I'll spend a lot of time on that in the sexual health videos. Okay, so why would perimenopausal women use contraception? Of course, hormonal contraception is still a great option for symptomatic patients who wish to avoid pregnancy. It's not a hard no. You absolutely can use menopause hormone therapy, but hormonal contraception in the form of birth control, pill rings, things like that could be helpful. It also can help calm that storm or the zone of chaos of perimenopause. It helps a lot with bleeding control. It has a little bit better bleeding control than some menopause hormone therapy options, but it also offers contraception for patients that are really, really concerned about getting pregnant during this time. And it can help with some mood instability for sure too. So it's not a bad option, but it may not be the option for everybody. There's no perfect algorithm for every patient. All right, so there are times when it's time to just break up with birth control. The World Health Organization criteria says that 35 years of age, migraines, and hypertension. So birth control used in midlife needs some really careful evaluation on who it benefits, who the risks are. But basically, you've heard me say the WHO criteria: over 35 who smoke, with migraines with aura, or women with uncontrolled hypertension should avoid oral contraceptions. Decision making really needs to be individualized and involved a shared discussion between the patient and the provider, because it's not this one size fits all. By mid-50s, most women no longer need contraception due to that natural decline in fertility. So stopping is usually important around that time, but also women have that fear. So oftentimes I'll tell them stop for about a month, get on another form of birth control. We can always check hormone levels, check FSH and LH, just to kind of see your menopausal status, but we can't check it while you're on birth control. It'll be inconclusive. So we need to kind of get you off of it in order to get a really good hormonal analysis on labs. The only time I ever will check labs on birth control is if you use an IUD. It's important to remember that oral contraceptives for birth control contain higher doses of estrogens as well as progestins. They are synthetic compared to the standard menopause hormone therapy. So it makes them more potent and sometimes riskier for women in midlife. So when we think about those patients that may want something to help with their symptoms that have that history of smoking, migraines with aura, or uncontrolled blood pressure, that's where menopause hormone therapy, especially in transdermal options where it doesn't have to do a first pass on the liver and lead to blood clotting, can also be really important. options for them. For those with an IUD, particularly non-hormonals or levonorgestrel IUDs, these can be left safely in place for as long as desired, even in the menopause transition, unless complications arise. So again, transitioning off of birth control is a shared decision, very nuanced, and it can be a really good option for certain people. In terms of perimenopausal treatment options, we have contraception plus period control. That's where contraception works really well. We have orals, implants, injectables, patches, IUDs. You could consider a uterine ablation where they go and they burn the lining of the uterus. And for about 80% of patients, they stop bleeding after that, but it's not a birth control option. So usually you'll need to get a tubal, or a partner, if you're with a male partner, can get a vasectomy. Hysterectomy also could be an option, never going to be a first line option, but that could be an option for really irregular bleeding. In terms of mental health, you could also use oral contraceptives, micronized progesterones, antidepressants, counseling. Again, these are all these discussions that deserve care in this transition. There's also a lot of sleep disruptions that happen during this time. Sleep hygiene practices, eliminating the sleep disruptors, maybe doing a sleep study. Micronized progesterone works so well on working on those GABA receptors in the brain, so it helps with that calming and sedating and really helps with those disruptions. And then you have sexual health, things like sex therapy, some of the other medications that are out there, flibanserin, bremelanotide, testosterone therapy, vaginal estrogen, and addressing all that. These are all really common symptoms during perimenopause and deserve to be discussed. So again, hormone therapy in perimenopause, things to talk to your provider about. Usually I start with progesterone in my perimenopausal patients. Helps with sleep somewhere around that 200 to 300 milligrams. Usually we'll start at 100 and work our way up. It can help with just the mood lability, the anxiety, the moodiness. Not the best profile all the time for bleeding, but sometimes it can be helpful. Vaginal hormones for estrogen, for vaginal dryness, pain with sex, recurrent urinary tract infections, and you want to continue on your hormonal birth control if you feel good on it and it works well. You don't have to stop it, but you need to consider other options if it's not working for you. And then again, perimenopausally, I often will have patients consider a small dose of testosterone therapy for low libido, even though we don't have anything that's FDA approved. And even though the consensus statement, which we'll talk about in the sexual health lecture, talks about it for postmenopausal women, I use it all the time in perimenopause as well. Okay, so let's move on to hormone therapy in menopause, or what we call MHT, which is menopause hormone therapy. So menopause hormone therapy is going to be a combination of different hormones. You have estrogen, and estrogen can be used alone or in combination with progesterone during this time frame. You also have progesterone, and you must use estrogen. You must use it with estrogen, if you have a uterus. I talked about that a few slides ago, and it's for the prevention of endometrial cancer, because estrogen thickens that lining of the uterus, and the progesterone acts as a check and balance to keep that lining thin, preventing you from bleeding. And you also can use progesterone, even though they'll tell you you can't, if you do not have a uterus. There's a lot of benefits for sleep and mood benefits and anxiety, so we use it a lot off-label for patients that are just not having the best sleep benefits. I want you to understand that there are other reasons that we may use menopause hormone therapy against some off-label things, but it is FDA approved for persistent, bothersome vasomotor symptoms. So those are going to be things like your hot flashes and your night sweats. The genitourinary syndrome of menopause, so that vaginal irritation and dryness, as well as for osteopenia and into the prevention of osteoporosis. Can't be used for FDA reasons for someone who is in full-blown osteoporosis, but it is for prevention, and it does some really good benefits. But again, we use it off-label. And there are some anecdotal and some research on just mood, brain, other things like that as well too. Okay, so who can take that? The international guidelines recommend that hormone therapy can be started as soon as menopausal signs and symptoms start to appear, and that can be in those late 30s, early 40s, but on average right around mid 40s into 50s. Women with primary ovarian insufficiency, which we've talked a little bit about through some of the slides, are going to require earlier and continued use of hormone therapy, at least until the normal age of menopause. And that's going to protect them from the associated postmenopausal chronic conditions. So osteopenia, the vaginal dryness, all the different things. Current users of hormone therapy can remain on treatment indefinitely, even lifelong if indicated, or at least until such a time that the patient asks us to stop. Okay, so this is a table that just has the contraindications for systemic therapy. My big contraindications are if there's any undiagnosed vaginal bleeding, potentially a history of breast cancer, but again, that doesn't preclude a patient anymore. It's a conversation that I have with every patient that wants to about breast cancer. It's kind of become a gray zone. If they have any type of coronary artery disease or a history of clotting or strokes, but again, every woman deserves to have this conversation because there are options for them. And then those are really kind of, and any active type of liver disease. Those are kind of the contraindications, but again, I feel like every woman deserves this conversation. So what are the benefits of menopause hormone therapy? We're going to see symptom reduction, quality of life improvement, reduced risk of osteoporosis, diabetes, cardiovascular disease, some dementia, maybe some depression, bowel cancers, early death, so many different benefits. In 2021, the State of Menopause Society revealed that 73% of women were not currently treating their menopausal symptoms. And unfortunately, that is because of the ramifications of the Women's Health Initiative, and that is really frustrating. So hopefully we start seeing more women get treated for these symptoms because there is such an unmet need. In terms of the timing hypothesis, it states that the benefits and the harms of hormone therapy are related to the proximity in which it began following the onset of menopause. So it's best to start menopause hormone therapy within 10 years of menopause. Usually that's going to be before the age of 60, but it doesn't again mean that it's a hard no that you can't use it. Again, it comes down to your decision with your provider, having that shared decision. You really want to try to intervene before the disease sets in, especially with heart disease, but a lot of times there are some options for patients. There are non-hormonal options, but hormonal options may be an option as well. Is it too late for you? Again, this really individualized conversation. If you're outside the window, it doesn't mean you can't take it. It just means that the benefits may not outweigh the risks, and that's why it's important to have this discussion with your provider. So why does everybody think it's bad? There's such a fear around MHT that it causes breast cancer. Remember, I talked about this earlier on, and I said most people are fearful of breast cancer, but the number one killer of women is heart disease. A lot of the fear around breast cancer largely stems from the WHI, or the Women's Health Initiative trial. The WHI was the largest women's health prevention study ever conducted, and it was launched in 1991 by the NIH. It enrolled over 160,000 postmenopausal women between the ages of 50 and 79 to evaluate the risks and the benefits of hormone therapy and its role in preventing age-related diseases such as heart disease and osteoporosis. So when early results were released in 2002, they were widely publicized in the media, often without any kind of nuance. Headlines focused on increased risks of breast cancer, creating fear among patients and providers. And I'll also have you note that the average age, again, for this study was someone right around 63 years old. They had multiple risk factors, smoking, heart disease, all these different things. And again, that's kind of where this timing hypothesis came in. They really didn't look at the younger women into that perimenopausal years where there are so many more benefits that come out with it. What was often overlooked is that the increased breast cancer risk was associated with the combined estrogen and progestin therapy. Again, we have to remember the synthetic hormones that were used. And even the absolute risk was relatively small. In contrast, women who took estrogen alone, those who were without a uterus, they actually had a reduced risk of breast cancer in the long-term follow-up. And the study had some limitations. Like I said, many of the participants were not the typical age when we should initiate menopause hormone therapy. They were at 63, and they were already more than 10 years past menopause, much different than the patients that I personally treat in my practice and that most do. So despite the nuances, the media soundbite of hormones cause cancer kind of stuck, and the stigma really exists today. So many women got off of these medications, and we had a huge uptick in the use of SSRIs and anti-anxieties, and now we probably only have about 5 to 10% of of women that are in menopause, perimenopause transition using hormone therapy, and it's really frustrating. So our role as a clinician is really to kind of help patients understand the context that for healthy women in their 50s who are close to menopause, the benefits often are going to outweigh the risk when it's appropriate to use MHT. So let's talk a little bit more about the WHI. I'm not going to harp on it too much, but in 2002, this Women's Health Initiative, WHI, they held a press conference to announce the early results from the combined hormone therapy arm, which used conjugated equine estrogen, or something that we know called branded Premarin, and medroxyprogesterone acetate, which is Pravera. Or it was a conjugated equine estrogen plus this medroxyprogesterone acetate, so it was called a PremPro. The trial was stopped early due to findings that suggested an increased risks of some conditions: breast cancer, heart disease, stroke, blood clots, and urinary incontinence. But you heard me say, again, the average person taking it was 63 years old, so that should tell you a little bit, not your typical patient. At the same time, there were also some benefits that were reported. There was actually a decreased risk of bone fractures, colorectal cancers, and overall mortality. But the problem was how the information was presented and how it was interpreted. As we know, statistics lie. The headlines emphasize the risks, especially breast cancer, without putting the risk in context of absolute numbers or absolute risk. The nuance that the risks were small and mainly relevant to older women starting therapy late after menopause was completely lost. And the result is that millions of women stopped hormone therapy almost overnight, and clinicians became hesitant to prescribing it, even for women who could benefit. So this moment shaped this really huge lasting stigma around hormone therapy that we're still really working to correct today. So what did we actually learn from this study? After a long-term follow-up, the WHI results told a very different story than the initial headlines suggested. Overall mortality, hormone therapy was not associated with an increased risk of premature death or death from cardiovascular disease, breast cancer, or other causes over 18 years of follow-up. When we looked at the estrogen alone arm, women who took estrogen without a progestin or those with a uterus actually had a reduced risk of breast cancer and were less likely to die from breast cancer compared to placebo. Looking at quality of life, MHT significantly improves quality of life for women with those bothersome vasomotor symptoms, the hot flashes and the night sweats. In terms of stroke and cardiovascular events, there was no increase in the severe strokes that caused disability or death. And the later reanalysis actually showed that the increased cardiac risk was mostly seen in women who started later than those 20 years plus after menopause. So not in women who started closer to menopause or even in peri. Breast cancer nuance risk, combined estrogen alone actually reduced breast cancer incidence by about 23% and the breast cancer deaths by 40%. That's actually rarely discussed in the media, but it's one of the key takeaways. So when it's prescribed appropriately with nuanced care and you're given informed decisions, when women are given good decisions and help, they make good choices. So MHT is not only safe, but it actually can improve symptoms and long-term health outcomes. I like to point to this study that was put out by Dr. Avram Blooming and Hodis and Langer, and it was a 2023 critical review by them that re-examined the WHI data, and it actually challenged the narrative that menopause hormone therapy drives breast cancer. And the key takeaways from the reviews were that combined estrogen alone, conjugated equine estrogen, significantly reduced breast cancer risk and mortality, showing about a 23% reduction in diagnosis and fewer deaths compared to placebo. And that combined estrogen and MPA, or estrogen and progesterone, when started with hormone therapy, in the younger women does not increase breast cancer mortality, even in women with a history of breast cancer. The supposed increase in breast cancer risk with the combined medication in the WHI was largely influenced by a low incidence of breast cancer actually in the placebo group. When it was put into perspective, it would amount to less than one extra non-fatal breast cancer case per 1,000 women per year. There was no consistently statistically significant associated remains between the combined estrogen and progestin and breast cancer after the protocol adjustment. So what this is saying that the risk was actually overstated, it was misinterpreted, and while the protective effects of estrogen alone is often overlooked, it also reinforces the message that context, nuance, and shared decision-making matter when counseling patients about menopause hormone therapy. So some pearls. As you keep hearing me say, shared decision, nuanced care. There is no algorithm for this. Everybody gets different methods and medications and things. There is no one size fits all approach. What may work for you may not work for another person. So trying several options may have to be the case to get it right. Even if you're working with a great clinician, we don't always get it right the first time, and that's why it comes down to a lot of hand-holding, and also why I often, when I start hormone therapy, will layer my hormones one by one so that we can work through any of side effects or difficulty. So I want to dive in a little bit into the different options that are available for you so that if you are a clinician in our practice or you're seeing another clinician, you have this available to you. Estrogen therapy exists in many options: orals, transdermals, and compoundeds. Orals can be dosed up to twice a day, and it does go through the liver. It has this first pass on the liver, so it does raise some clotting factors, but those clotting factors regress back to the normal ranges after 1 year of use. There is transdermal options, and those have no venous thromboembolic risk, and it does not affect sex hormone binding globulin. So they are safer for most people, and there's not a clotting risk with them. And then there's also compounded options. These are not FDA approved. We don't know that what benefit is derived, and sometimes they can be poorly absorbed. But for some patients that don't tolerate the FDA approved options, that is where compounding can come in really nicely. And you can see here there's different forms that can be used. I've put this graph here because what it talks about is the different estrogen hormone therapies. There's beta estradiol, which is going to be bioidentical to what you produce in your own body. It comes as patches, orals, topicals, and vaginals. There is vaginal that is localized to the vaginal tissues. We talk a lot about it in the sexual health portion of the course, but there also is a vaginal component that has a systemic absorption that can be used if you can't tolerate patches, orals, and topicals. Conjugated equine estrogen is going to be your Premarins. It exists as an oral and a vaginal. Those are synthetic. Because it's synthetic doesn't mean it's bad, but usually we try to do bioidentical first, but it doesn't work for everybody. And then there is esterified estrogens, which is going to be your Menace, and then ethinyl estradiol, which is going to be other options that are going to be more synthetic as well. In this graph, you're going to see these are some options for estrogens and progestins combined. So progestin is going to be a synthetic option of hormone therapy, and those are going to be things such as maybe Bijuva or Combi Patch or Climera Pro. For options. Some people like doing them together. There's Femheart, and then there's another one that we'll talk about briefly called Duave. It's a serum estrogen. It actually has conjugated equine estrogen or Premarin as its estrogen, and it is a synthetic form, as I've been saying, but it also has a SERM, a selective estrogen reuptake modulator called basodoxifene. And what that does is it works on making it anti-estrogen in certain places, so like in the breast tissue and things like this. So this could be a great option, and there's some wonderful studies that are coming out about using this option for patients that have breast cancer. So we're doing a lot of work seeing what options are for patients. So again, shared decision-making, nuanced discussion. It's no more, no, you can't take hormones if you've had breast cancer, which is kind of exciting. In terms of progesterone, I want to spend some time on talking about these options. There's oral micronized progesterone or permetrium that's going to be bioidentical to what you produce in your body. It's derived from wild yam plants. It has a really small particle size. And it's the exact duplicate of progesterone produced by the human body, and it makes it more metabolically, and biological effects are going to be completely different than synthetic. Because it's bioidentical, a lot of people want to use that, but there are synthetic options that are out there, and it doesn't mean they're bad. Micronized progesterone that's bioidentical doesn't always have the best bleeding profile, and that's oftentimes where synthetic formulations may work really, really well. Some of the synthetic formulations are going to be norethindrone, levonorgestrel, or desogestrel. And those could be options for patients. And then there's also other progestins, the ones that were used, for example, in the WHI, which is Provera or medroxyprogesterone acetate. There's another one that's spironolactone derived. It has some drospirenone in it. It's called Slind. It's actually used as a birth control option. But that, again, it comes down to shared decision making with you and your clinician. You really need to take a progesterone if you have a uterus. That's the only thing that is going to protect against endometrial cancer. You need to use it at least 12 days per month in the calendar month, or you can take it cyclically. Most of my patients, that's cyclically, excuse me, or you can take it every night. A lot of my patients like it every night, especially if they're using micronized progesterone, the bioidentical one, because it works on those GABA receptors in the brain and helps with a calming and sedating effect. It's also some good evidence that it could be a good standalone treatment, especially for perimenopausal patients for hot flashes and night sweats. One of the big things I want you to take away, though, is that if you choose to use progesterone in a transdermal form, it's really not well absorbed. It doesn't protect the uterus, and it's not something that I normally give. I honestly feel like it's a waste of money, and it's never an option that I give my patients. I want to point out that there is a rare condition called autoimmune progesterone dermatitis, and that's for patients that do not tolerate any progesterones. And so again, a hysterectomy may have to be an option, or with removal of the ovaries, but patients can work with allergists on this to discuss what options are, but I just kind of want to put that out there. You heard me talk a little bit about something called Duave, and that's the one that has Premarin in it with a SERM. So a SERMs are these medical multitaskers. They block estrogen from connecting with breast cancer cells, and it keeps the cells from multiplying. So it's anti-estrogen in places. So at the same time, the SERM kind of acts as an estrogen. It can help boost your estrogen levels in your bones, prevent osteoporosis, but it's a combination, again, of that estrogen and basodoxifene, which is the SERM, and it works well for a lot of patients for hot flashes, night sweats, the prevention of osteoporosis. When we look at these two ingredients together, the ingredients bind to and activate these estrogen receptors, and what it does is it acts as a target in those tissues. So there's a lot of good information that's coming out about this newer drug that's out there as well, and so it's doing really well for a lot of good benefits. So how long can you take your menopause hormone therapy? There's no longer a maximum amount. We don't even say lowest dose, shortest duration. It's the dose that's right for you, and it's however long that makes sense based on your symptoms, discussion with you and your healthcare provider. You don't have to routinely stop anymore at age 65, and many of the benefits derived from menopause hormone therapy actually diminish after you can discontinue it. So that's really important to think about. You may need to lower the dose with aging due to that decreased metabolism, but again, it comes down really to shared decision making and working with your clinician. All right, so this was a bigger chapter, but the next chapter is a little bit smaller, 5.2. Next up, we're going to discuss non-hormonal treatment options for patients that may not want to use hormones in the case of menopause hormone therapy. So I will see you in the next chapter.